Okay,
differently.
what problem are we trying to fix? Are we trying to fix prior auth? Are we trying to fix co-payment? Are we trying to fix adherence? So the model, which is fundamentally shifting site of service, fixes none of those things. All it means is that the doctor can hand the pills to the patient. Doesn't fix the prior auth situation. Does not fix benefits design. Does not, just by the establishment of a dispensing pharmacy in a practice, fix adherence. So when practices talk to me, and they talk to me about this, let's see, what day is today? Every week. So there's two ways you can compete. You can compete on price or you can compete on quality. Make a case for us to fracture that relationship. I'm not in charge of that relationship. I'm a nobody. These relationships are handled in the company at the highest possible level. Now, if you tell me you have built a specific methodology for managing orals in the practice, and you can show me what your process is, I would rather pay you for that process than I would think about this goofy re-engineering of the system. Because, listen, I didn't fall off the turnip truck yesterday. I know there's margin on this. You're gonna wind up in the same predicament you got with people who are payers, not me, but people who are payers saying, you're prescribing that drug because you're getting more money out of it. It's just nuts. And you cannot negotiate volume discounts. You're too small. What will ultimately happen, I think what's going to ultimately happen is if I live to see the day where comparative effectiveness research actually can happen and have teeth, and maybe I'll be retired by then they will be able to negotiate on class.
Right.
And so my point is, I don't care where the drug gets things, but don't pretend for a second it's going to make your life any easier. It's just not.
Right.
The real impediments to dispensing these drugs and getting patients to adhere are related to other defects in the system.
Right. I actually totally agree, not to be agreeable, I totally agree with you, Mike. And it's one of the reasons why, and I mean, I looked at this, we recently had a COA board meeting, and because of this issue, that we realized how many practices right now either dispense, this depends on state pharmacy laws, or actually operate a retail pharmacy, as some practices do, again, based on state laws, that we had a number of practices come to us for exactly that reason and said, look, COA is a nonprofit, community oncology. What we need is some standards. We need to make that quality case. And it's just not practice by practice, but like at everything at COA, that's what we need to do. So guess what? Last Monday, 2 Mondays ago, the board of directors of COA, we announced it, approved forming the Community Oncology Pharmacy Association, COPA, within COA.
Another acronym.
Another acronym that I can talk to my wife
That's
about.
going to be Cabana.
Oh, yeah.
So that's the
COPA, right.
Community Association
But,
of, right.
no, it's me coping with
Right.
it, COPA. But basically the idea of seriously, and I said to the board, we need to really do another thing as if we don't have enough to do. But it was so essential because you have this issue of 25 to 35% of drugs coming out of the pipeline are orals. Because you have all of the issues that you listed, Mike, in terms of that, starting with the clinical side, that the bottom line is that's what we're doing. And we're going to try to do exactly that in terms of providing more of these standards, that quality case, that issue, and overcome exactly some of those barriers, which you did a good job
Now,
listing.
I think criticism of the service